secondary to another illness like cancer that may be helped with cannabis. It is important to note that an anxiety disorder is not the same as anxiety or negative mood more generally. An anxiety disorder is very specifically defined in the medical world. And different types of anxiety disorders can be very different in terms of their presentation. We will discuss PTSD, social anxiety disorder, and generalized anxiety disorder. Not too surprisingly, those disorders can be quite a bit different from one another, and cannabis may impact them in different ways. For PTSD, many veterans anecdotally report a positive effect for cannabis products. In fact, we will talk to a former veteran who now runs a nonprofit about his previous experiences with cannabis as well as his current work. At this point, we do not have any large clinical studies on whether cannabis products may be useful for PTSD. More generally, there's been some suggestion that CBD may be helpful, and also some experimental work suggesting that THC may be helpful when combined with exposure to an anxiety-triggering stimulus. There are a couple of trials ongoing that will shed some light on whether cannabis, and specifically CBD, is helpful, and whether that is a function of the combination of THC and CBD or one or the other. In addition, there's been some work with CBD in the treatment of social anxiety disorder, suggesting the possibility of an effect of CBD in the 300 to 600 milligram range. Again, we are waiting on more rigorous studies for all three of these disorders. It will be critical to know whether CBD works by itself or only in combination with THC, and at what levels. We will cover these topics in this module, and we will listen to an interview with Dr. Christine Rabenak, who has been doing cutting-edge research on the combination of THC and exposure therapy and the implications for PTSD. Stay tuned, because this is an Okay, so in this lecture, we're going to talk more about the prevalence of anxiety disorders and also the epidemiology of anxiety disorders. So we're going to start off with some information here from Reams and colleagues in this 2016 paper. They did a systematic review of the prevalence of anxiety disorders in adults and identified a total of 48 reviews in describing the prevalence of anxiety across population subgroups and settings. And so here are some key pieces of information. First of all, anxiety disorders are quite prevalent. And we've mentioned this already about being the most prevalent psychiatric disorder. Also more prevalent in women, more prevalent in young adults, more prevalent in people with chronic diseases. And then there are all also both similarities and consistencies across different cultures. And so you see here different prevalence rates in European cultures versus other areas of the world. Okay, so the epidemiology of panic disorder. Around 2.8% of the U.S. population is affected in any given year. Close to 5% of the U.S. population affected at some point in their lifetime. Women are twice as likely as men to be affected. The prevalence is pretty similar across cultural and racial groups in the U.S. and seems to occur also in cultures worldwide. In terms of the epidemiology of generalized anxiety disorder, estimates of about 4 to 7% of the general adult population will have generalized anxiety disorder. The median age of onset of generalized anxiety disorder is 30 years. There's a wide range of onset, though, throughout the lifespan. So just because 30 years is the median, keep in mind, again, there's a wide range in terms of when you're likely to see onset. Again, women are twice as likely to have generalized anxiety disorder as men, and the majority of individuals with generalized anxiety disorder have a comorbid mental health diagnosis, especially depression. So just highlighting this again, generalized anxiety disorder oftentimes co-occurs with depression. Okay, now let's talk about social anxiety disorder. Age of onset. Look at this, much earlier than with the other disorders, right? Age of onset is typically around 13 years old. So, again, much earlier. Highest prevalence rates is found in the 18 to 34-year-old demographic. It's more common in women than men, again. Lifetime prevalence is estimated between 3 and 13%. These patients are less likely to see a physician, which makes a lot of sense considering the disorder, than other anxiety disorders. And in this case, there's also high comorbidity with agoraphobia. Okay, now we're going to talk about PTSD. And we're going to start off by talking about risk factors related to PTSD. Now, PTSD can occur at any age, including childhood. It can affect anyone. The likelihood of developing PTSD is likely higher following a high-intensity stressor, right? So again, the greater the stress, the greater the trauma, the higher the likelihood. Physical proximity to the stressor or trauma also impacts an individual's likelihood of developing the disorder. Lack of social support and pre-existing psychiatric conditions also increase likelihood of developing PTSD. There's also some evidence of a heritable component. So depending on your genetic background, you also might have lower or greater risk of PTSD. So what about the different risk levels for developing PTSD based on the type of traumatic event? So there's been a little bit of research on this, and you can look at this more at the websites below. But these are some of the results. So rape, the estimated risk is about 49%. Severe physical beating or physical assault, 32%. Other sexual assault, almost 24%. A serious accident or injury, like in a car accident or a train accident, close to 17%. And then being involved in a shooting or stabbing. An unexpected death of a family member or friend. Life-threatening illness. Natural disaster here at the bottom. So this gives you a range from 49% all the way down to 3.8%, depending on the type of trauma that a person experiences. So clearly that's an important aspect of PTSD. Now, there are also some common comorbidities with PTSD. Once again, as with other anxiety disorders, depression is commonly comorbid with PTSD. Other anxiety disorders are also comorbid with PTSD. Substance abuse, substance use disorders, commonly comorbid with PTSD, especially among veterans. Somatization disorders and dissociative disorders, those are also two categories commonly associated with PTSD. So let's talk about combat vets. So according to the Department of Veteran Affairs, estimates suggest PTSD is diagnosed in about 20%, up to 20% of Operation Enduring Freedom and Operation Iraqi Freedom vets have PTSD. Up to 10% of Gulf War vets have PTSD. Up to 30% of Vietnam War vets had or have PTSD. So soldiers with symptoms of PTSD often face rejection, both in terms of their military peers, but also by society in general. Another important point, veterans with TBI, traumatic brain injury, are more than twice as likely to suffer from PTSD later on than those without a TBI. And we're going to talk about this more when we get to the TBI module. But again, with veterans, this is a very important population, and at high risk for PTSD, high risk for TBI, high risk for opioid use disorder, and high risk of chronic pain. Right? It's a very important thing to remember in terms of the context for why veterans want access to cannabis. Okay, so in summary, prevalence of panic disorder is about 5%. Women are twice as likely to have it. Generalized anxiety disorder, prevalence is about 5%. Women are more likely to have it. Median age of onset around 30. With social anxiety disorder, lifetime prevalence somewhere in that same range, around 5%. But age of onset here is much earlier, at age 13. That's average age of onset. And then PTSD can happen to anyone, anytime. And again, there's a number of variables that predict risk, but the intensity of the trauma and the type of trauma are also known to be related to odds of, chances of having PTSD. Combat vets, not surprisingly, are very high risk, and that varies slightly depending on the conflict. And again, very important to remember that combat vets with PTSD are also highly likely to have other problems, including traumatic brain injury, chronic pain, opioid use disorder, etc. So in this lecture, we're going to talk about the etiology of each of these 4 anxiety disorders, and we're going to start off with generalized anxiety disorder. So we don't know a lot of the specifics about what causes generalized anxiety disorder, but we do know that there are several factors that seem to be important. One of them is having a family history of anxiety. Another that seems to be important in terms of a mechanism that is involved in the development of generalized anxiety disorder is GABA. So GABA seems to play a role, and part of the reason we know that is that medications that have been used to treat generalized anxiety disorder typically involve changes to the GABA system. So another important factor is recent and prolonged exposure to stressful situations, childhood trauma, maladaptive cognitions and assumptions. So regarding a situation or a person being unsafe until proven safe, that's kind of one of these maladaptive cognitions. Another is that it's always best to assume the worst. You can imagine that is not necessarily a very adaptive cognition. And then also, researchers have repeatedly found that people with generalized anxiety disorder have maladaptive assumptions, particularly about danger. Okay, so that those cognitive components, those maladaptive cognitions and assumptions seem to be very important in terms of the development of generalized anxiety disorder. So let's talk now about how does panic disorder develop? How does this work? Well, there's definitely a biological perspective on this, and remember that panic disorder involves all different types of bodily or physical symptoms that go along with the panic attack. So we also know that an increase in norepinephrine and sympathetic nervous system arousal and increases in heart rate are also involved in panic attacks. So along with epinephrine, norepinephrine underlies a fight or flight response that's also connected to increases in heart rate. And the thinking here is that panic attacks and panic disorder involve basically a
misfiring or a wonky fight-flight system. And you see here this little graph on the right, just showing you sort of baseline heart rate, and then maybe during a relaxation phase, the heart rate drops some. When a panic attack starts, the heart rate skyrockets, right, and stays up during the panic attack, and then finally starts to come down toward the end of the panic attack. So again, wonky or misfiring, misdirected, whatever fight-flight system seems to be important with respect to the biology of panic attacks. So some more here in terms of the biology of panic. We know that the brain's important, obviously, and specific structures and functions are likely to play a role, particularly those circuits, those networks that involve the amygdala and the limbic system. And so those circuits, those structures play a critical role in how we experience fear, and both instinctive fear, like being afraid of snakes or dogs, but also fear that's learned. So learned fear from life experiences. That these are the systems that encode that, and that seems to be an important pieces of the puzzle with respect to how panic disorder can develop. Now let's talk about social anxiety disorder. Here we know that genetics are important. There have been twin studies that have found a significant genetic component, though the exact genes are not yet known in terms of the specific genetic mutations that can be important for social anxiety disorder. So the family environment is another important factor. If you have an anxious parent, if you grew up in an environment characterized by frequent criticism, these are two environmental variables that seem to be related to or predict the development of social anxiety disorder. Learning from specific traumatic or humiliating events. And so, for example, during childhood, if there's a traumatic experience that involves public speaking or being bullied, those are also variables that can predict subsequent development of social anxiety disorder. All right, switching gears now, talk for a minute about how does PTSD develop? What are some of the risk factors? So there are certain characteristics and environmental factors. We already talked about some of these in terms of the severity of the traumatic event, etc. But also here are a couple that we have not talked about so much. So basically, your psychological adjustment pre-trauma is important, right, for predicting what happens after exposure to a trauma. And you can imagine there are things like having a history of child abuse or general adversity during childhood or family instability. Those are variables that predict a higher risk for developing PTSD after exposure to a traumatic event. And so basically, there's support out there in the research literature, both for stress vulnerability models, so being more vulnerable to, some people are just being more vulnerable to stress, and also stress sensitization models, so that over time people become sensitized to stress. There's support for both those models in terms of influencing the development of PTSD.